Welcome to this special clinical series, From Vascular Curiosity to Neurodegenerative Disease, a consensus statement for the diagnosis and management of MacTel Type 2. For decades, macular telangiectasia type 2 was viewed as a vascular curiosity characterized by its subtle vascular abnormalities, including telangiectasia vessels and late-stage leakage. Emerging research and clinical consensus, however, have shifted the paradigm of MacTel type 2 from a primary vasculopathy to a complex neurodegenerative disease centered on the dysfunction of Müller glial cells, which support both the functional and structural integrity of the retina and the subsequent loss of photoreceptors. As the understanding of the metabolic and genetic components of MacTel type 2 evolves, clinicians are recognizing that standard metrics of visual function, specifically Snellen visual acuity, are insufficient for capturing the true burden of the disease. More appropriate measures include difficulty reading, metamorphopsia, and paracentral scotomas. In this 4-part video compendium, an expert consensus group of renowned retina specialists help us move beyond the traditional eye chart to explore the metabolic underpinnings, multimodal diagnostic protocols, and emerging neuroprotective therapies that are transforming the standard of care. Join us as we explore these perspectives to ensure that no patient is left behind in the Snellen trap. And for more details, we encourage you to use the QR code on this screen to read the full written consensus statement. To treat a disease, we must first correctly name its origin. For years, the term telangiectasia led us towards a vascular-first mindset for MacTel type 2. However, 100% of the MacTel type 2 expert consensus group now characterizes the disease as a primarily neurodegenerative condition affecting the Müller glial cells as photoreceptors. It begins not with a leak, but with a metabolic error.
The pathophysiology of MacTel, really, the understanding of it has changed certainly over my career. It started out, we thought about this sort of as a vascular disease primarily, but recent evidence and further knowledge of this disease really supports the idea that this is a neurodegenerative disease of the retina, like other diseases, but different than our initial understanding, where we saw these early vascular changes as a precursor on angiography and imaging. So really, my understanding has shifted quite dramatically over the last few years to think about this as a neurodegenerative disease.
TEL stands for telangiectasias, but that's kind of a misnomer. It's really a kind of a neuroinflammatory or neurodegenerative disease where you get loss of tissue. That's why on an OCT you often see these cystic cavitations, and you get these secondary kind of vascular changes leading to the tortuous look that's often characteristic of MacTel. But really at its core, it's a disease where you get slow loss of neural tissue. A lot of people and a lot of the current understanding thinks maybe this originates at the level of the Müller cells, which are these important structural support cells that help not only maintain structure of the retina, but also secrete naturally ciliary neurotrophic factor, which is a survival factor for neurons. It helps keep the neurons alive. So when you get loss of those Müller cells, you also get decrease of local CNTF.
And as a result, patients have deficits. They start with maybe some paracentral scotomas once they have some ellipsoid zone loss. And then eventually that correlates to functional problems like diminished reading speed, and eventually can get more serious than that where they have reduced visual acuity. But that's basically the process.
Roughly 150,000 individuals in the United States have been diagnosed with MacTel type 2. Although there are roughly 2,700 new cases per year, underdiagnosis and misdiagnosis contribute to a potential underestimation of patient numbers. Symptoms typically appear between the ages of 40 and 50 years, and the mean age for diagnosis is 57 years.
We often diagnose patients when they're in their fifth, sixth decade, a lot because by then they unfortunately have significant changes. And at that stage is when we can recognize it very easily, and people are referred to us. Ideally, we want to catch it before then with these kind of identifying really subtle changes on primarily OCT.
According to 71% of the MacTel type 2 expert consensus group, the disease is frequently misdiagnosed in general retina practice.
MacTel type 2 sometimes can be a challenging diagnosis. I think when patients come in, they are usually adults over the age of 40, and they can have these vague visual complaints of reductions in their central vision or blank spots in their central vision.
This is actually a common problem. So I think it depends on what type of practice the patient comes from and whether that practice has OCT and other diagnostic capabilities. So I think the more diagnostic capabilities there are in the practice and the more experience that the providers have in diagnosing this disease, the more likely the referral is to actually equate with MacTel. But we're seeing a lot of referrals, sent in as macular holes and sent in as dry macular degeneration and wet macular degeneration as well. And again, we do get referrals straight from optometric practices, some of which actually do not have, OCT. Like if they're located, in malls and places like that, they just diagnose an abnormality and give us the top 3 differential diagnoses and make sure that the patient gets seen by a retina specialist. And then, of course, we, at the other end of things, we do get referrals from retina specialists where the diagnosis is correct, but they're really looking for another opinion, or they're looking for enrollment in a clinical trial or for a therapeutic strategy.
MacTel type 2 is considered a slowly progressive disease. More than half, 57% of the expert consensus group, consider ellipsoid zone loss on OCT as the earliest clinical sign that raises their suspicion for MacTel, compared to 29% that feel paracentral grain of the retina, and 14% that feel parafoveal thinning on OCT is the earliest clinical sign to raise suspicion. When it comes to patient-reported symptoms or issues, 71% believe difficulty reading despite good Snellen visual acuity most commonly corresponds to early MacTel type 2, followed by a central blur or gray spot, scotomas, and distorted or melted vision. Nearly half, 43%, felt patients are typically asymptomatic until advanced disease.
Well, if it's an early stage of the disease, again, you may have some very subtle changes, just like graying of the retina you might see on color pictures. It may be more in the temporal aspect of the retina. You may have early on some flattening of the foveal reflex. Again, that would be something you'd see on an OCT image. As it progresses more, we start to see these telangiectatic vessels. We start to see right angle venular changes. We can start to see crystals in the retina in some patients. On the OCT, we might start to see some cystic changes in the internuclear or the outer plexiform layer, these cystic-like changes. And as the disease tends to progress, we then start to see these ellipsoid zone loss or loss of the photoreceptor outer segments and the photoreceptors themselves. We can see pigment starting to migrate into the retina, and then eventually, loss of the larger areas of the ellipsoid zone that start to extend into the foveal center. That's when we really start to see visual acuity loss. So it can be more later in the disease where they're actually measuring visual acuity loss. But it can be slow in some patients. So the patient comes in, they're 20/50, the next year they're 20/50, the next year they're 20/50. But if we look at the OCT, we can see changes that are progressing. These ellipsoid zones are going away. And, there is a potential for a neovascular complications too. They could develop chorioretinal neovascularization. And such a patient may have a more acute change in their vision, and we may see blood in the retina, actual fluid leakage in the retina now in these patients that can lead to fibrosis and scarring. But that happens in more of a minority of the cases, and it's in the later phases of the cases where there's a lot of proliferation of the RPE into the retina itself. So it's a slowly progressive disease, but in most patients, it tends to continue to progress along that course. And over time, most of the patients develop ellipsoid zone loss. And then over more time, most of the patients that develop the ellipsoid zone loss develop that loss that extends into the center of the fovea, where you get more significant levels of visual loss.
And eventually the patient has symptoms of scotomas in their central vision, difficulty reading, difficulty seeing small print. And this is a bilateral condition, and it affects both eyes and progresses slowly over time.
There's only literally a dozen symptoms in all of ophthalmology, and yet there are 1,000 different eye conditions that can cause those 12 symptoms. So it's hard, and I think it's more just when you hear patients complaining about whether it's difficulty reading, difficulty in low light situations, following the news ticker on the bottom of the TV, it's hey, that should kind of get our spidey sense going to say, let me take a closer look.
Studies have shown BCVA may not adequately capture MacTel type 2 progression or visual function. The example shown here depicts disease progression with expanding ellipsoid zone loss and eventually the fovea surrounded, despite a good BCVA of 20/40.
To me, that's one of the big struggles as we think about expanded earlier diagnosis for MacTel, is that it's difficult for patients to verbalize what their problems are. These patients have profound impairment of reading speed, and so what I would like to see is the utilization. And reading speed is a difficult clinical test because it's somewhat subjective and it's dependent on the individual patient. However, as a comparator for an individual patient over time, I think that it would be an excellent way to screen these patients. But I think that's one of the real difficulties for current diagnostic strategies, is that patients have a hard time sort of quantifying what their problem is.
What we're using and what tests are most sensitive are two different things. What we're using is smell and visual acuity. Outside of the clinical trials, it's just not practical to do microperimetry, which is probably the most sensitive test to detect vision changes. The clinical trials also did reading speed, but again, reading speed on any one patient is really tough because there can be a high degree of retest variability. And it's not something, again, we routinely do in clinic. So, unfortunately, we're kind of left with vision, even though, if there was a way to do a faster microperimetry that made it a little more practical, we could consider using that. I do think AI will eventually kind of give us a translation between what we see on OCT and the microperimetry changes. So we'll almost be able to kind of look at the structure and get kind of an overlay of what a microperimetry would look like based on the structural changes. We're not quite there yet.
Paracentral scotomas is the typical way this sort of begins. And a paracentral scotoma is a blind spot really close to the center of vision. And reading is the classic task that becomes difficult if you have paracentral scotomas, because we don't read one letter at a time like we do when we look at an eye chart. We scan the page and we look at basically multiple letters or words at the same time as their eyes are moving. So patients can't always verbalize and say that's what's happening, but they just say, look, I have trouble reading as I'm getting older. I have trouble doing things I normally do. I can't see the TVs clearly. Sometimes when I see a face, it's a little bit blurry. And sometimes they just say, look, I don't know what it is. I just have trouble seeing. The doctor's job is to elicit a more detailed history, including symptoms. You have to distinguish it from other diseases that cause crooked letters or wavy lines. So, you have to ask the right questions.
Thank you for joining us for this video compendium on MacTel Type 2. As we journey from the microscopic failure of serine metabolism to the macroscopic challenges of differential diagnosis and the surgical frontiers of neuroprotection, the goal is clear. Increase awareness, utilize multimodal imaging, and intervene within the therapeutic window to preserve visual function. In the next video, we'll take a deep dive into diagnostic protocols and the importance of looking beyond visual acuity to identify early structural changes and functional loss. For more details, we encourage you to use the QR code on this screen to read the full written consensus statement. Together, we can move from passive observation to active preservation.